It's great to see so many of you joining us from different countries and time zones. It's a great pleasure to introduce Professor Dr. Thorsten Steinfeldt, a highly respected physician with an outstanding professional background, for this expert session entitled No General Anesthesia Without Nerve Blocks. Professor Steinfeldt is chair of the Department of Anesthesiology, Intensive Care and Pain Therapy at the Emergency Hospital in Frankfurt, Germany, and also chairman of the Scientific Group for Regional Anesthesia of the German Society of Anesthesiology and Intensive Care Medicine. And he has also received the ESRA Lecture Award twice in Genova and Dresden. Professor Steinfeldt, the floor is yours.
Thank you, Beatrice, for the nice and kind introduction. And I just will share my... Yes, so it works. Yes, I have no conflicts of interest. I'm just a working anesthesiologist, as everybody in the audience. So welcome and good evening, ladies and gentlemen. We will talk about the aspect of combination of general anesthesia with nerve blocks. And I think generally speaking, it's like this, that people think, okay, you do general anesthesia or peripheral nerve blocks or regional anesthesia, but from the practical point of view, there are many reasons to combine it always. And my hypothesis is that there is no general anesthesia without peripheral nerve blocks, without regional anesthesia. And this is something I want to explain to you, and I want to convince you to do more blocks and more blocks, maybe from day to day. So what is our perioperative challenge? The challenge is that we have some problems postoperatively, especially in the PAJUNK. For example, we have people, we have patients who suffer from postoperative delirium, especially in the higher ages, more than 70 years. We have an increase of workload because of the general anesthesia, because of opiates. And this is the main issue which we are confronted to. And of course, there are some patients which suffer from cognitive dysfunction in the postoperative time period, more over some months. Okay, so what are we talking about? We are shortly talking about peripheral nerve blocks, some techniques and the evidence. We are talking about opioid reduction. This is a very important issue. And we are talking about the reduction of anesthetic requirements or anesthetic consumption. We are talking about delirium and postoperative cognitive dysfunction. We are talking about emergence, about patients' vigilance, and we are talking about processes. So what happens in the PAJUNK unit, and how, at the end of the day, we could implement our peripheral nerve blocks in our daily routine and in our department. So for everybody, it's clear that we are working nowadays with a multimodal anesthesia concept. This is logically, and for some operations, it's clear that we combine peripheral nerve blocks with general anesthesia. The concept is always the same. We want to reduce the opioid requirements, and we use a lot of non-opiates like NSAIDs or paracetamol, and these are the most important instruments. So what kind of indications do we have and what kind of blocks we could apply? For upper extremity, it's clear: an interscalene block, superior trunk block, infraclavicular block, axillary nerve block for shoulder to hand surgery. That is more or less something like a standard that the people always apply peripheral nerve blocks, for example, with shoulder surgery. For lower extremity, we have our femoral nerve blocks, the femoral trigeminal blocks, fascia iliac compartment blocks, sciatic nerve blocks, of course, lumbar plexus blocks. And the IPEC block or the PAJUNK block or whatever else. So we have a lot of good instruments to work for lower extremity. And what very some kind of fanciness is the truncal nerve blocks for the transverse abdominis plane block, the quadratus lumborum block, the serratus anterior plane block, pectoral nerve blocks, for example, interpectoral or pectoserratus blocks, the cervical plexus block. For example, in our department, in our hospital, for plastic surgery, for spine surgery, for spongiosal graft, for clavicular fractures, for rib fractures, for trauma of the thorax. And one issue, what is not really a big topic in this presentation, are continuous catheters. Of course, you can apply catheters for a lot of indications, but just to say it and describe it quickly, catheters are for me not that important because our patients have to get ambulated very, very fast and they have to leave the hospital. And you have a lot of problems, technical problems with catheters. This is one reason why we reduced them over the last years to a minimum, for example, from 2,000 catheters per year to more or less 200 per year. Okay, so let's talk about opioid reduction. This is really a very, very important issue and a big advantage if we combine peripheral nerve blocks with general anesthesia. So the intraoperative opiate consumption can directly be reduced by using peripheral nerve blocks for shoulder, for example, the interscalene block. You can reduce it to 1/3, or for total knee arthroplasty, you can reduce it same to the 1/3, or for thoracotomy. You can use a paravertebral block, or you can use a serratus plane block or a rectospinal block. And it will work perfectly and will reduce the postoperative pain really to a minimum, and you will apply always a lower number of opiates. The same for laparoscopy. If you use transverse abdominis plane blocks, there are not so many studies which describe it really that quantitatively, like I describe it here by the data of Büttner and Fang. But I think our daily routine shows it every day that we can reduce our amount of opiates really on a very low level. So, and even in the postoperative phase, you can see the different directly, for example, in the PAJU zone, that you, for example, take the red line, you have a high level on opiate requirement, and it's very, very lowered by peripheral nerve blocks. If you look on the orange line, and of course with catheters, you have it over the long time, always on the lowest level. But I think it's just a dream to put always catheters in all patients in all corners of the body. That's not possible. So just have a view on the single shot block on the orange line. This is a really high discrepancy if you compare it to general anesthesia alone. So what kind of opiate side effects we can avoid is, of course, postoperative nausea and vomiting. You have a lower sedation, you have a lower drowsiness, you have a lower urinary retention, you lower respiratory depression if you use peripheral nerve blocks in combination with general anesthesia just by lowering the opioid requirements. You have lower postoperative ileus, and of course, we think that we have more or less a lower number of persistent users, so of lower number of chronic pain or abuse of opiates. But the data for that for the evidence is not really convincing. Okay, so we talk about anesthetics, and even anesthetics are very interesting in that circumstances. For example, if you perform a general anesthesia alone and you apply a MAC of 1.2, and you combine in these patients a peripheral nerve block with a general anesthesia, like an interscalene block for shoulder surgery, you can reduce the amount of volatile anesthetics and even propofol, if you do a TIVA, really by a half. more or less by a half, especially by older patients. The same with epidural anesthesia, the same with transverse abdominis plane blocks for a lot of operations, interventions, or with erectospinal block. You can definitely reduce the amount of volatile anesthetics. And that means that you have a lower number of cardiovascular problems. You will have a better vigilance postoperatively, lower hepatotoxicity. You have a lower environmental problems. You have a faster emergence. Your patient will be directly awake, and even with a TIVA, with a total intravenous anesthesia, it is perfectly able to combine. So if we have a look on the hemodynamic stability, if we lower the number of volatile anesthetics, the dosage of volatile anesthetics, you will have a more stable patient. You will have a lower requirement of vasopressors, more or less a half that is really convincing, and you will use a lower number of fluid balance. And this is as well good for the patient. And all these things are convincing to combine general anesthesia with peripheral nerve blocks. So what is important for the processes? So if you reduce the dosing of volatile anesthetics, you need no time for emergence, because your patient will be awake on the point. So you don't need the OR, you don't need a special room for emergence or whatever else. So you have a faster operation room turnover, because your operation room is faster free. And you have a smoother PACU and stuffing flow, because your patients do not need such a lot of help, like patients which have postoperative vomiting or dizziness or whatever else. So you have lower agent cost and lower logistic, and you can work with your staff more easy. So what is happening to the brain? So we talked about that we can reduce the incidence of delirium and maybe of postoperative cognitive dysfunction. Yes, and indeed, there's some data which indicated that the delirium incidence will be reduced from 30% to 50% or 10% or 5%. It depends on the age of the patients, because age is the highest risk factor for postoperative delirium. Or patient with cognitive impairment preoperatively have a problem, or patients with a high dose opiate administration, they will have a higher incidence of delirium. And so there's some data which shows it even for the postoperative cognitive dysfunction. And the postoperative dysfunction occurs more often in patients with a higher age. With an age of 65, you could have an incidence with general anesthesia of something like 30 to 40%. So what happens if we use our peripheral nerve blocks with a postoperative delirium? So we can see a reduction in case of hip fractures if you use the fascia iliaca compartment block. The first studies, more or less 10 years ago, indicated that the first time that we can have peripheral nerve blocks could have an impact on the incidence of postoperative delirium. And this is actually really clear. And there are a lot of studies which show that. The same for total knee arthroplasty, or for thoracic surgery or abdominal surgery. And there is some data which shows that these patients have better cognitive scores postoperative if we combine general anesthesia with peripheral nerve blocks. This is shown by the blue line compared to the red line, and this is highly significant. So less opiate, less neuroinflammation, and a lower incidence of postoperative cognitive dysfunction and delirium. And this is really a nice benefit and advantage of the combination of these techniques. So we have some other data, for example, the Ramsey scores, Ramsey sedation scores, which could be measured in the postoperative phase. And even in this case, you can see high difference between general anesthesia in combination with peripheral nerve block compared to general anesthesia alone. So the time to alertness is much shorter and decreased, and the patient experience is very positive because the patient, they will talk very fast after the surgery about their experience and that they feel good and that they don't feel any pain. The cognitive clarity is different, and we suggest that we have maybe a reduced risk of falls. And this is very important for our patients because our patients get more and more earlier embolized. So what are the advantages with regard to processes? You have a predictable extubation because you can extubate your patient directly in the UR very quick after the suture. You have a reduced intraoperative interventions because you have a higher hemodynamic stability. That is good. You have a smooth awakening. The patient are not that coughing and they're not that aspirating, and that means that the patient will awake with more comfort. And a very important thing is that you have a PAJUNK bypass eligibility. So maybe you have patients which do not use a PAJUNK, or the PAJUNK time is shortened to a minimum, and this is very important for the process in the UR. And at the end of the day, if you do so many peripheral nerve blocks, for example, we perform per year more than 14,000 surgical interventions, and we perform more or less the same number of peripheral nerve blocks. So in the mean, we have more than 1 block per patient, and that means that our residents, and we have something like 25 residents, they perform a lot of blocks and they are very close to it. They have a high success rate because they have a good skill building, because every day they have to perform, every day they have to block a lot of nerves and do a perfect analgesia. So have a look on the right, red box. Hopefully you can see it and it's not hidden by our pictures. So our patients actually are ready for what after the PAJUNK phase in the half of the time compared to general anesthesia. That means that even in the operation theater, we increased the number of surgical interventions. For example, 2021, we did 10,000 surgical interventions, and actually we performed 14,000, 4,000 more in the same time. And that is really great. And yes, you can see it in our operation schedule that the patient, that we have a higher turnover of operations, and that means you can perform more operations. So this is economically of high relevance. Okay, it's oh, I can. Okay, it works. That's good. All right, so the economic view is maybe important just to advocate for peripheral nerve blocks. Your throughput with a PAJUNK is shorter. You use less antiemetic in opioid drugs, so you reduce the costs. You reduce the readmissions. You have a lower incidence of delirium with all that trouble around the delirium, and your liability will increase. And that means, so with a lower opioid adverse events rate, you have really a lower rate of malpractice, and that could explain maybe why costs could reduce to a minimum. So the implementation is very important, and so you should implement your peripheral nerve blocks in the standards. So that everybody in the preoperative area who is working for the patient consent, he should just directly explain how the system, how it works in your hospital and what kind of block you recommend or not just recommend. What you would say is part of the procedure. That is most important, that you say a peripheral nerve block is not just a recommendation by the anesthesiologist. It is part of the whole procedure. It is part of the operation. And by this, everybody would say, yes, I want the block. And of course, it is clear for the patient and they understand it really perfectly if you explain it by this. So we have different indications from shoulder surgery about total knee arthroplasty or hip arthroplasty to breast surgery or inguinal hernia or hand surgery. So we have a lot of blocks. And of course, you can see on the right side the opioid reduction with all these peripheral nerve blocks you can apply. And so for each standard, peripheral nerve blocks have to be listed. And so if you start with this, just start with the standard with just one block per operation, per surgery intervention. And then you have to establish these techniques. And after the next phase, you have to optimize it. So you have to have a look on the local anesthetic you use. If you take long working anesthetics, or really short working anesthetics like mepivacaine, because sometimes maybe it causes trouble in the postoperative phase. The patient are not happy with it because maybe the skin is too long damp or whatever else, and you can adapt your local anesthetic dosage, of course. So from the training, how we train it. So there are some rules which are important. First thing, hands-on from day one. So at the day when the residency starts in our hospital, the patient have to learn to intubate. They have to work with a laryngeal mask. Of course, simultaneously, they have to do the first blocks. First day, first block. That's the most important rule. And the next is we want to have our residents very, very fast out independent. So they have a high procedure rate of more or less 20 or 15 blocks per week or whatever else, maybe more. And so after a time of 15, for example, 15 sciatic blocks, they are maybe able to work more or less independent. That works. It depends on the resident and depends on the consultant which was guiding the resident. So enable, never block. This rule means that there should never be a reason why a patient do not get a block. Sometimes a consent lacks or whatever else. So the consultant have to care for it, that the consent will be done and the patient get the block always. And if surgeons get on the nerves of the residents, you have to help them. And of course, you will care for it that the patient get the blocks, of course. And time should never be a reason, but we will talk later about it. So speed is success. On the one thing, yes, of course, the residents, they get a good education and they get a high number of procedures, but they have to be really fast. And that means quality is nice, but speed is important as well. And speed is one part of the quality. And therefore you need, of course, a high number of procedures. Never take over. A special rule for consultants. So our consultants never take away the needle or the probe. They just take their hand, put their hand on the hand of the resident, and they show them what kind of movement they have to do with the probe or with the needle and how they get the needle really perfectly visualized on the ultrasound screen. So this is one very important rule because of course, in a lot of hospitals, consultants like it to take over. And so they have the fun which the resident should have. Okay, next is the ratio of consultants and residents. And I always say you need a ratio something like 1 consultant and 3 URs, 3 residents, and that works. And next rule is ask the recovery room. So what I expect is that everybody who performs blocks, he has to ask in the recovery room how the patient is and how the anesthesia quality was in the recovery area. So I have to put it in a nutshell and to summarize. First, if you want to see some evidence, you can have a look on these trials, very nice trials especially for this issue, and just have a look on it and you can read it. But on the other hand, I know it from my hospital and some other colleagues. If you just start to implement peripheral nerve blocks in that quantity, you will really restructure your OR and your PACU unit. It's completely impressive. So just to summarize it, we can reduce our opiate consumption to 50% compared to general anesthesia alone. We can reduce our volatile agents with 40%. You can reduce the delirium incidence with about 40%. The postoperative cognitive dysfunction, I'm not sure how many percent because the incidence is relatively low in our patients. The alertness of the patient is perfectly, you will really have a highly different, perfect and increased alertness of the patient. That's nice. And you will have a very efficient PACU unit with peripheral nerve blocks. And of course, you will have economic benefits. And just for me, it's not that important, but sometimes it's important for you to get other people convinced, like surgeons or like your administration. So always nerve block in combination with general anesthesia. This is my dogma. This is my hypothesis. And so start with your highest volume procedures and implement peripheral nerve blocks in your standards. And so you will have a lot of fun with your residents and your anesthesiologist because you will create really block champions in your OR. And yes, and so it's nice for the patient, it's nice for the OR, it's nice for the surgery and the surgeons, and it's perfectly nice for your team. So I'm ready for questions.
Yes, I'm here. Okay, thank you very much for this wonderful, excellent presentation. So the first question comes from Ashok Lal. The webinar speak delayed one panelist. In laparoscopy, like bariatric surgery, mostly surgeon is giving tap block. My question is how much is effective comparing laparoscopic versus tap block?
Okay, that is really a very important question because this issue is relatively new, that the surgeons perform the transverse abdominis plane blocks. And a good friend did a study about this issue in this hospital, and hopefully they will publish it soon. And they had two groups, TAP by surgeons and TAP by anesthesiologists. And unfortunately, I have to say there was no difference. And from my point of view, I think it depends on the surgeons. If the surgeon is really close to that procedure and he's doing it well and it will work. And so I think it's not important always that the anesthesiologist is doing the block. When the surgeon is doing it, it could be as well good as well, of course. And in this case, I have to say, yes, it will work in the same manner as if the anesthesiologist is doing it.
Thank you. Second question, reduction of MAC or propofol by 2 times. Risk of awareness?
For that reason, just to reduce the dosing and to be sure that we do not have awareness, we always use EEG measurement and measurement of anesthesia depth. Okay, what questions do we have more? Okay.
What do you see? What do you use for pain control after the block wears off in the setting of a patient who stays a little bit longer and has no catheter?
Okay, so very important and good question. So we reduced the number of catheters, as I told you at the beginning, and in the same time, we implemented dexamethasone for all patients. So every patient gets 8 milligrams of dexamethasone during the introduction, and for postoperative vomiting and nausea, and of course for a longer duration of the nerve block and a lower postoperative pain. It's a perfect co-energetic. And I think it's very important to use dexamethasone. This is one point. And of course, mostly we use ropivacaine. And afterwards, non-opiates.
Another question. Good evening, Professor. I'm Fitri from Indonesia. My questions are, one, she has two questions. What type of local anesthetic agent do you use or recommend? What is the dosage?
Okay. Mostly we use ropivacaine 0.5%. And we combine it often with mepivacaine 1%, half-half. For example, for sciatic nerve block, we use, for example, 15 ropivacaine 0.5% and 15 mepivacaine 1%.
And when do you administer it? During induction or at the end of surgery? Thank you.
Depends, regards on the process. For example, if the resident is working in the OR with one patient and he ordered the next patient very early, this is always my wish. And for me, it's more practical that the block is ready. I just say the resident, okay, just do the block now awake. And afterwards, if you are ready with your other operation, you will be very fast with the general anesthesia and you do not need any help more. And then we do it in awake status. And in other situations, it's the choice of the resident, if he wants to do it in anesthesia or if he wants to do it awake.
Do you recommend dexamethasone for postoperative multimodal analgesia?
Always. It's basically important. You always should use dexamethasone. 8 milligrams.
Another question from Italy. Thanks for this webinar. One question. Do you recommend to write the side of the PNB on the informed anesthesiological consent?
Yes. Yeah, this is a very, very important question. And yes, in a comment, because yes, if you do so many blocks, sometimes there will be a misunderstanding and you will block the wrong side. So this is something I learned by Admir Hatschik, the sentence, stop before you block. Always ask, is this the right side where I do my block? And of course, we did a lot of mistakes in the past. And I could say in 5 years in the hospital where I work today, we had more or less, maybe 10 mishaps. And hopefully we will be better in future.
How are you managing the delay of surgery in early start of resident rotation?
Okay, the first point in one operation room should be always a patient with lower requirements of anesthesia techniques. For example, an ASA1 patient or ASA2 patient with no other problems, short operation, quick surgery, all these things. Everything should be easy for the first point. And the second, if a patient has bigger problems, major surgery, whatever else, perfect patient for the second position. This is always one rule. And the next rule is that the resident has always to order his next patient very, very early so that we have enough time to overlap these introductions.
Can you please summarize the commonly used agents for different PNB? Most effective with best result and which to avoid?
So the concentration of local anesthetic, as I told you before, more or less half-half, mepivacaine and ropivacaine, 0.5 and mepivacaine 1.0.
You say that speed is a measure for quality.
Yes.
How do you handle residents with poor probe needle handling that take much more time both to actually learn the block and to apply the block?
That means that we have to guide that resident very good. And we always should tell them some rules, how things work very effective. They need some tricks just to know where to put on the probe at first, how to start. Some inner rules you have to implement in your brain. For example, you have always a needle in your hand. So when you start, the needle is in your hand. So when you put on the probe on the right position and you have a perfect image, start working and start puncturing. And do not hesitate and just search for your needle and depack it and whatever else. You just have to be ready. You always should be ready to puncture.
What blocks would you recommend for laparoscopic robotic gyne surgery, hysterectomy, for example? Is there space for QLB type 1 and 2?
Yes, of course, a standard, and it's easier, really easier, is always the transverse abdominis plane block. For me, it's a basic block. Everybody should do that very easy, but you need a special number for it because you have to work with the fascias and you have to be sure that your local anesthetic is really in the right in the right fascial interspace. This is really important. And so you get a good feeling for it. And you should learn to apply the transverse abdominis plane block very dorsal. So more or less just directly before your transverse abdominis plane muscle gets to the fascia, to the transversal fascia. And afterwards, if you are safe with it, then you can maybe try to work with quadratus lumborum blocks. I'm not that sure what is really better. For example, if you take a lateral quadratus lumborum block or a posterior quadratus lumborum block, the people discuss, and sometimes I'm not really sure where is the local anesthetic distribution. Sometimes I do a lateral quadratus lumborum block, and afterwards I think, okay, it's more or less a posterior block. So I'm not sure if this discussion is always, yes, if we really find the truth. You have to work with it, and you have to collect your experiences.
Another question from Italy. How important do you consider the use of adjuvants in local regional blockade, such as clonidine or cortisone?
Okay. Very, very clearly, and there's only one adjuvant which is really relevant, and it's the most relevant, and it's not toppable. This is dexamethasone. And the combination of dexamethasone with clonidine or dexmedetomidine does not make any sense. So just feel good and use dexamethasone. You won't have a better block with a combination of other adjuvants. And all other adjuvants have not that potency.
Thanks. What is your advice to do nerve block before or after induction of anesthesia?
I know in the 20 years ago, or maybe 10 or maybe 5 years ago, we were a little bit discussing, should the patient be awake? Is it important to avoid nerve damage or nerve injury? And we learned over the last years that there is no really evidence or good data which advocates for awake patient with regard to the avoidance of nerve injury. And so that is the reason why we actually recommend by the German Society of Anesthesia that it's your decision to make it in an awake state or sleepy state or during anesthesia. For me, it's just relevant for the process. Sometimes it does not make sense for the induction of a general anesthesia because maybe the operation starts in 1.5 hours, but maybe it makes more sense just to do the block now and the general anesthesia later, just direct before the surgery starts.
Do you perform spinal anesthesia plus regional blocks for hip and knee, arthroplasty?
It depends. For example, if
you prefer general
yeah.
anesthesia?
If there's an indication for spinal anesthesia, and if the patient wants a spinal anesthesia, of course he gets peripheral nerve blocks because the spinal anesthesia stops working after some hours. And afterwards, the patient has the same problem as a patient who has a general anesthesia. And that's the reason why even these patients get, of course, peripheral nerve blocks, for example, in spinal anesthesia, no problem. For example, for knee arthroplasty, you can perform an IPEC block and a trigeminal femoral nerve block, a trigeminal block for knee arthroplasty in spinal anesthesia.
Do you use any device to monitor the depth of anesthesia?
Yes, we have a narcotrend monitor just to measure the anesthesia, an EEG measurement.
All patients are not fit for regional blocks. What should we do in such cases and in emergency surgical procedures? And all the anesthetists are not competent to block.
Just repeat the...
All patients are not fit for regional blocks. What should we do in such cases and in emergency surgical procedures? And all the anesthetics are not competent to block.
I think the question, this question is focused on the aspect of emergencies. And even for emergency cases, it's the same like with general anesthesia. The consent is not that important. Of course, I'm really always afraid to do neuraxial anesthesia techniques in patients without any consent. That's not possible. But for example, interfacial blocks, there are no contraindications. Maybe they are deep blocks. For example, with regard to ESRA, the pain block is a deep block. So maybe there you should be a little bit aware because of bleeding if patients are anticoagulated or whatever else. But all other blocks are really no problems, especially interfacial blocks. And even for plexus blocks or whatever, it's nerve blocks. You're working with ultrasound. And in an emergency case, it's perfectly to get an axillary block for hand surgery or lower arm surgery.
Given you mentioned that you don't do many catheters, do you use routinely any perineural adjuvants? Dexamethasone, dexmedetomidine,
Yes, yeah.
clomidine, or magnesium?
Poor Beatrice. No, we don't use perineural applications of adjuvants because a lot of studies have shown that the benefits are really very low. Maybe you have an enlargement of duration of a local anesthetic duration of some percent, but that's clinically not relevant. So always systemically, intravenously, and never perineurally.
Do you suggest doing a lower limb major nerve block as well?
Just repeat the question, Beatrice.
Do you suggest doing a lower limb major nerve block as well?
Yes, why not? Yeah, it's okay.
Okay. How do you monitor and minimize post-operation nerve injury associated with regional anesthesia in the ambulatory setting?
That is good. It's a good question. So for ambulatory patients, it is very important that your patients get well informed during consent talks, how they should behave after the surgery when they're at home. That you explain how long is the local anesthetic working and when gets a sensory feeling in the preoperative way. And yes, that is important because for the patient it's very difficult, for example, when they have a block persisting at the next day in the morning, they get a little bit afraid, and therefore they need really a lot of information how the block ends and when.
How do you teach? Dual guidance or US ultrasound alone?
We are guiding, or yes, we are teaching even nerve stimulation for some blocks. For example, for the axillary plexus block, it is really nice to work with that instrument, especially for the younger residents when they have problems to image the musculocutaneous nerve or to image the radial nerve or whatever else. Then it's a nice opportunity to know how nerve stimulation works, and that is one reason why we do it. And actually, it's all even now. It's a little part of the standard, but of course we all know it. If you work longer with ultrasound, after a while you're never looking on the nerve stimulator. You just work on the ultrasound image and work with these pictures. And that works perfectly. In my daily practice, for me personally, the nerve stimulator is not really a function. But for residency, I think it's a nice tool.
What is the difference between fascia iliaca block and femoral nerve block?
Nice question. Over the last decades and years, we have seen a lot of studies, maybe with a discrepancy in results. And some people say, yes, the fascia iliaca compartment block could be something like a 3-in-1 block. So you get a lateral cutaneous femoral nerve, and you get the obturator nerve, and you get the femoral nerve. These three nerve structures. And by the anatomical view, it's impossible. But some people said the local anesthetic will spread that deep and close to the lumbar plexus that it will work. I don't believe it, and a lot of studies shows that it does not work. The real expectation you can have, it is always a good femoral nerve block. That is safe. And maybe with a incidence of 30% or 20%, you will have a lateral cutaneous nerve block as well as an adding to the femoral nerve block. So I say my special opinion is that it depends on your mood. If you started your day on your left foot or on your right foot, you do a femoral nerve block or a fascia iliaca plane block.
Any recommendation for the injection pressure monitoring during performing of a block?
I don't believe in the topic.
Mm-hmm.
I never measure injection pressure. I'm just talking with a nurse, and I'm just talking with myself when I use the syringe. And so if you feel a high injection pressure, it's always a problem, not because of nerve injury, maybe because there's a fascia between your target and your needle. And that is one reason why the injection pressure is important. But I don't need it for by safety reasons. I just recognize it. Okay, now I have a higher pressure, and I use, for example, the higher pressure if I do a PAJUNK block. A PAJUNK block with a low pressure block, with a low pressure injection is a wrong block, because then it will be a femoral nerve block because you are inside the iliac muscle. And this is a problem. And it is very important that you are beyond, that you are underneath the fascia of the iliac muscle. And therefore, you need a high pressure injection block. Otherwise, a PAJUNK block won't work.
Why do you use mepivacaine for everyone? Doesn't the block last longer if we only use ropivacaine?
Yes, that's true. It would work longer. But on the other side, I do not want that hard motor block with ropivacaine pure. And I want to have a really short onset time. And the onset time in combination with mepivacaine is, by our clinical experience, shorter. And our surgery is that fast that we need a perfect short onset time. We use mepivacaine in combination with ropi.
In 2020, you released a paper that advised not to mix LA. Why do it now?
We do not mix. We inject this each afterwards. So we start, for example, with mepivacaine, a dose, and after injection of mepivacaine, we inject ropivacaine. So we never mix it in a syringe.
Is it iliogastric and ilioinguinal nerve block are enough for informal hernia repair in very sick patients?
I would combine it with general anesthesia or spinal anesthesia, but it's perfectly for the intraoperative phase, and it's perfectly in the postoperative phase. And for example, if you combine it with general anesthesia, you can lower your anesthetics really to a minimum because these blocks are working tremendous well.
Have you got experience with ESP block at different level and different operation?
ESP. I think interscalene blocks are important. Yes, of course. In the past, 20 years ago, we were on the level of the thyroid cartilage, and over the last years, we went closer to the supraclavicular region, and now we're talking about the superior trunk block, of course. So the level changed over the years.
Now I have a long question. Good afternoon. Great inspiring lecture. Thank you. Do you use higher dose of DEX for patient more than 100 kilos? Do you use ketamine or magnesium as part of MMA? Do you perform? We stop there, and I will.
Okay.
The other question.
First of all, no, we do not adapt the dosing of the dexamethasone because we have always the same dosing, the same amount in preparation, and we do not adapt it. Maybe, of course, for children we adapt it, of course, but roughly. And from our side, we never use higher dosages than 8 milligrams. But for example, our orthopedic surgeons want more than actually would like to apply 16 milligrams of dexamethasone for knee arthroplasty, for total knee arthroplasty, and yeah, because they are in an ERAS program.
Can you explain why after spinal anesthesia, especially in cesarean section, patients have motor and sensory block, but still have pressure sensation over the upper abdomen, despite this sensation transmitted by small diameter nerve?
I have no answer for it.
Okay, let's go to the next question.
Should be more experienced and professionalized in obstetric anesthesia. Ask another expert.
If a patient is septic and coagulation profile deranged, patient is planning for above knee amputation because of his knee issue, would he be a good candidate for peripheral nerve block only?
Okay, the problem is anticoagulation and nerve blocks. As I said, some blocks are deeper. For example, I would always avoid a proximal sciatic nerve block punctured from anterior in a patient with coagulopathy. That's not possible. But for example, if you do that block from dorsal, you have really a short way to the sciatic nerve block. For example, infragluteal block wouldn't be that problem. But from anterior, it's really very deep and more or less muscle traumatic, and I wouldn't do that because of bleeding problems.
The last question. What is your regime for the follow-up of patients who received nerve lesion after a peripheral blockage?
This is a very important issue. Of course, we have that patients which suffer from nerve injury postoperatively, but as we experience it always when we observe these patients very clear, mostly the problem is a surgical problem. And that I really could say that we have a patient with a nerve injury by regional anesthesia reasons. I couldn't say any name, or I have no person in my mind, no patient in my mind over the last 100,000 blocks. And we know that the incidence is very, very, very low, and maybe just estimated with 1 to 10,000. And I would say with the actually patient safety, possibility of ultrasound application, maybe it's something like 0.5 to 10,000. And from my point of view, I've never seen one. Maybe just for some days. That is possible. That we did a sciatic nerve blocks, and the problem and the patient suffered from nerve injury for maybe more than 3 weeks or something like this. But this is not really a nerve injury. Nerve injury for me is something which, according to definitions, is something which takes over more than 3 months.
In the chat, I have a lot of compliments for you. That is very interesting topic and wonderfully presented. So the webinar has come to the end. I'm sorry, because maybe the question, we answered to all the questions. Very big thank you to you, Professor Steinfeldt, for this interesting presentation. Thanks to all of you to be with us, and thanks also to PAJUNK to organize this wonderful webinar. So have a nice evening, day, wherever you are.
Thank you all.
And thank you again for
Nice
this
evening.